This was managed conservatively. What you notice, this is trapezium and the whole metacarpal is falling apart under the pull of abductor pollicis longus. So first metacarpal base fracture is unstable and therefore they have to be relocated back. On the patient, now you notice here, while the volar medial fragment is sitting nicely on the trapezium, the lateral fragment, the radial fragment is gradually shifting more proximally under the pull of abductor pollicis longus, and therefore base of the proximal metacarpal 1 requires surgery. Now how do you do it? Now what is happening is there is a pull of the abductor, so you have to give traction. Now you want the finger pulp, the thumb pulp to be pointing toward the finger, and therefore you have to rotate it. What is the rotation? In the thumb it is pronation. Now you want the thumb to be pronated away from the palm. Now you want the finger to move toward the finger. So there's the third thing you will do, palmar abduction, palmar abduction. And you want the medial and lateral fragment to come together, so medial press. Once you have done it, two things, not only immobilizing the fracture fragment, but you have to counter it further, because again you have to neutralize it, and this is done by passing a wire from the metacarpal into the trapezium. So now they remain in place, and the wire in the CMC joint is removed after a month, 4 weeks. The wire is metacarpal is removed in 6 weeks time, and then mobilize it. How do you mobilize? Very easy. First thing is, tell the patient, start counting index finger, middle finger, ring finger, small finger. Start approximating the pulp of the thumb to index, middle, ring and small finger, and this is how you do it. Don't ask them to go this way. This is adduction. You have to go rotation. So teach this thing to the patient. This patient had a fall from the two-wheeler, and X-ray is described as normal. Now if you see a magnified view, what you see this part is overlapping, and you see this is convex and this is convex. So there is a double convex of the base, and there is a shadow away from the base. So probably something is happening, and we had this X-ray and we are missing something, and the patient has pain. So sure enough, a CT scan is obtained, and what you notice, this is a trapezium, the metacarpal is shifted out because of the effect of the abductor pollicis longus, and therefore this is the malunited metacarpal 1 base, and this requires malunion, this requires surgery, because a new bone has formed in more than a month's time. So open it dorsally, save the cutaneous nerves, erase the thinner muscles, go on the volar side, and this is the trapezium, this is the first metacarpal, this is the fracture side. Open up this thing, use the fine osteotomes which were described in the morning, 4-6 mm, and push it distally and get that back into alignment, and hopefully you'll be fine. Rolando fracture. So what you do, you have a good purchase on the metacarpal. This is the fracture, the first metacarpal base. Have purchase either on the radius or the second metacarpal, and now one assembly here, second assembly here, and use the distractor. Once you have this distractor, this can be brought more distally. What that basically does is, these fragments hopefully will fall in place under the effect of the pull on the capsule, and what that pull on the capsule is called, ligamentotexis.